the child is still less than 34 weeks of gestation, you have started long maturation, and you don't want to deliver yet that child. Is it clear? So you want to deliver the child instead after long maturation has been done, or you want to deliver the child after the child has a favorable weight for that is going to be favorable for life, provided you need to know that the weight that is favorable for life is actually something like 1,000 grams. So if you have a child that has intrauterine growth restriction, or you have a small gestational age with long immaturity, so in case where you have long immaturity, or you have intrauterine growth restriction with a weight which is not favorable for life, you need to do tocolysis in order to make sure that you can mature the lungs and you can increase the weight of the child. And what are the different drugs with class of drug which can be tocolytics? The first major class of drug, we have calcium ion channel blockers. Is it clear? Blockers. Example is nifedipine. And how do you give that nifedipine or nicardipine? Is it clear? So we give the nifedipine. To give nifedipine is 20 milligram tablet. Is it clear? We give 1/4 tablet every 15 minutes. 1/4 tablet every 15 minutes for 1 hour. Is it clear? Until the contraction stop. Is it clear? Now, if the contraction still persists, you continue by giving 1/4 tablet every 4 hours. Is it clear? If the contraction persists. Now, another class of drug after calcium channel blockers, we have beta agonists. Example of beta agonists, we have salbutamol, we have salmeterol. Is it clear? Now, the mode of action of calcium channel blocker is that it's going to block. Normally, you need to know that for contraction of muscles, smooth muscles like the uterus, you have calcium channel which is going to be inhibited by these drugs, nifedipine. Now, you need to know that what beta agonists also inhibit smooth muscle contraction, particularly at the level of the uterus. Normally, the beta agonists increase smooth muscle contraction at the level of the blood vessels, but is instead going to do inhibition of smooth muscle contraction at the level of the bronchioles and also the level of the uterus. Is it clear? By using the beta 3 receptors, it inhibits instead the uterine contraction. So salbutamol is going to inhibit, or salmeterol, or terbutaline. So those are the different drugs. Now, the next drug, we have non-steroidal anti-inflammatory drug, particularly endomethacin. We have other non-steroidal anti-inflammatory drug that reduces prostaglandin secretion, because prostaglandin secretion, you need to know that non-steroidal anti-inflammatory drug inhibits prostaglandin secretion, and prostaglandin is required for uterine contraction, cervical maturation, which is going to help you for tocolysis. So we have endomethacin, we have aspirin, we have ibuprofen, or we have also ketoprofen, which can help. Now, the next element, we have magnesium sulfate, and the posology of magnesium sulfate that is used in the case of tocolysis is different from the posology that is used in the case of to prevent convulsion in case of preeclampsia. Is it clear? So you use magnesium sulfate, and the mode of usage, the mechanism of magnesium sulfate is that what magnesium ion is going to compete with the calcium ion. Is it clear? Competes calcium ion. Is it clear? Since it's competing with calcium ion, you don't have calcium ion that is going to be there for the contraction of the uterus. Is it clear? So you have a patient that is not going to have uterine contraction. Now, the next element that is going to be used for the management of for tocolysis, we have also the next one, which is the fifth one is oxytocin inhibitor. Is it oxytocin inhibitor? Example of oxytocin inhibitor is atosiban. Is it an example of oxytocin inhibitor? You need to know that oxytocin is a major element that is used for uterine contraction. So if you use an inhibitor, it can help in tocolysis. An example is atosiban. So those are the different elements that you have to evaluate in order to prevent from the complication, which was premature rupture of membrane. Now, we need to also manage the cause. Is it clear? We need to also manage the cause of this patient. So in order to manage the cause of these patients, we said that the cause can be associated with an increase in intrauterine pressure or fragilization of the cervical incompetence or the cervical insufficiency. Is it clear? Now, the increase in intrauterine pressure is a cause that has already occurred. Is it clear? So you cannot treat that cause in the recent pregnancy. You can instead treat that cause in the next pregnancy by doing a good antenatal care consultation. Is it clear? With a good conception period, such that the child should not be macrosomic. Is it clear? The child should not have polyhydramnios. You use medication in order to prevent the polyhydramnios. You should prevent macrosomia in the child and all those other elements, gestational diabetes, which can promote macrosomia. Is it clear? Now, other element, the major element that is going to cause a cervical insufficiency or membrane fragilization is going to be infection, and those infections we said we have trichomonas. When you have diagnosed trichomona by using microscopy and you see biflagellate cell, your management is by using metronidazole. Is it clear? And it's a nitroimidazole. You use metronidazole, and that metronidazole you can use it either with uvules that you pass it intravaginally, is it clear, or intrarectally. Now, if you have chlamydia, in the case of chlamydia or in the case of mycoplasma or ureaplasma with intracellular microorganism, you give the patient, if the patient is pregnant, you give the patient azithromycin, but if the patient is not pregnant, you give the patient tetracycline, because tetracycline, for example, doxycycline, is not given in the case of pregnancy because it is teratogenic, and it is not given also in the case of children less than 8 years because affect the growth plate, is it clear, in the bones. Now, the next thing is that if you have a whitish discharge which is offensive with fishy smell, you can think of bacterial vaginosis. Is it clear? In the bacterial vaginosis, the major microorganisms that we had anaerobes, especially Gardnerella bacteria, Streptococcus, and Fusiform bacterium. Is it clear? Now, all these anaerobes are going to be treated with a nitroimidazole. Example, we have metronidazole, you have secnidazole, or you can also use even clindamycin. Is it clear? Provided you don't have a nitromethazole, you can use clindamycin for the management of these anaerobes. Now, the next one that we have also is candidiasis. If you have candidiasis being your etiology, you manage the candidiasis by using fluconazole ovules intravaginally. Is it clear? And now we also need to, provide that the candidiasis is persistent, you can now use also oral fluconazole. Is it clear? So those are the different elements that you must have in your management. So we have managed the complication, you have managed the cause, we have the background, and then the next element now is your follow-up.